Good morning. I know you all have been at it for all morning, right? And we're the last before lunch, as evidenced by the hardcore folks still here. I will give you the obligatory hua, like as an Army language, because we have a great leader with us today that it's my privilege to introduce. But I'm all about adult learning, so instead of hitting you with PowerPoint right away, I'm going to hit you with a quick question as I introduce Colonel Malat. And you can answer this question anonymously, and that's fine. I guess the question I have for you today is, are you healthy? Everybody's looking around like, what kind of question is that? Am I healthy? Well, are you healthy, right? So you've been to maybe a primary care manager this year. Maybe you had your blood pressure taken this year. Maybe you stepped on a wireless scale at home this year. Maybe you wear a wearable, a Fitbit. Maybe you actually have a consumable that tracks your cholesterol, that reports it through a wireless network back to your healthcare provider. But are you healthy? And there was an article this past week in the Washington Post that said the number 3 cause of death in the United States are medical errors, behind cancer and heart disease. Medical errors. With the advent of electronic health record and a number of electronic wearables in the healthcare industry, this is becoming an increasing challenge for us. And I would say that as part of your journey to consider insight-driven health as an emerging technology, an emerging industry. And we're just delighted today to have a great leader with us, Lieutenant Colonel Mark Malat, who comes to us today from the Defense Health Agency. And it's again my privilege to introduce him. He has his undergraduate degree in English literature from the University of Georgia, earned a master's degree in public administration and management information systems from Troy State University, and he has a PhD in policy studies from Clemson University in 2010. And one of the great things that he's doing now is leading research efforts for the Defense Health Agency. He also led a team and program manager for the Army Surgeon General on wearables and Fitbits and insight-driven solutions for the Army Surgeon General. His doctoral focused on the deployed and operational medicine aspect of military medicine. And what he's going to come talk to you today is about some of the advances that military health is making in the research area in this space of insight-driven health. Please join me in a warm welcome for Colonel Malat.
All right. Thank you. First off, before we start, I just want to make sure you kind of widescreen because I'm going to walk around a little bit. Is that all right? Poor guy. Okay, you're good? All right. Good morning, everyone. Mark Malat, if it's okay, it's a fairly intimate audience. I'll kind of walk around here in the front, so okay, kind of keep it a little bit more interesting. If you're like, please stop, I'm getting a little seasick, I will. I'll go to the podium. I'm fine with that. I understand. Thank you so much. I'm humbled to be here to be able to tell the story of what we're doing in military medicine. I'm going to focus today on things from look at that, wow. From a research perspective, I get the opportunity, I think it's probably the most fun I've had in a number of years, leading health IT and informatics research and notice I won't say DHA, for the military health system. It's a small but very important difference, and it's very important for me. I'm not focusing on one combat support agency. I focus on everything across the military health system. I understand who my customers are. Who is my customer? It is that soldier that's on the remote mountaintop somewhere. It is not my agency, right? All right. So I want to make sure that we're very focused on that. So I promised my good buddy in the back, Chris David, we were talking a couple weeks ago, and he's like, Mark, you got to start with a there I was story, right? So there I was, right? You always, the old soldier, you got to do there I was, right? But what's awesome, as a PhD, I was like, okay, but really? Do I get an analytic? I get to use an analytics there I was story, right? So like there's a couple of analytics people in the back going, you go, you preach, brother. All right. So there I was. And it starts really cool, right? There I was, Afghanistan, 2012. All right. Now let's get into the analytics piece. So here's what happened. I was sitting there. I had the opportunity to work as the CIO for Coalition Medical Care in theater for about a year. I had just come out of working as a professor for Baylor in their management department for their MHA MBA program. And we're having a problem figuring out relative workload, right? So now, anybody's like health data, you're like, oh yeah. Everybody's like, okay, really? There's it. So there I was, health data. This guy in the front, you're with me, I can tell. All right, health data, we're having a problem. Relative value units. How do I figure out relative workload of what's going on in my remote surgical places? We have about 16, 20 different surgical units that are spread all over Afghanistan. All 6 different RCs. And you couldn't really pinpoint by using the electronic health record that was in theater at the time exactly how much work was being done. All right? For a number of reasons, right? Medical rules of engagement. Who were you actually working on? What was going on? The use of the record in theater. In fact, Dave, thanks for the introduction. The preponderance of my research initially was on specifically how can I increase clinician compliance in completing electronic medical records. And unlike folks in industry, I've got a mandatory use environment. It's easy. I can just tell you got to do it. I can order you. I don't have to worry about incentive structures. It's disincentive structures, right? In fact, one of the policies that I studied and looked at that we put in place in 2012 was, there's another there I was for you, Chris. If you don't finish those that you start, you don't redeploy. Now, pretty good ability to kind of get some records complete. There was a whole follow-on study that I did about data and quality of the data. We can talk about that another time. So there I was, Chris. We're working. I can't figure out the issues. So what do you do with the data analytics? Okay, I've got this one data set, but it's not perfect, right? It's all messy data. What else can I use? I pull in clinicians, pull in everybody else. What we use to be able to triangulate data analytics and problems that we're having was I pulled in aircraft maintenance data. Right? Anybody that's worked with Department of Defense or worked in aviation before, that is one thing that is tracked, right? Very well tracked. How many blade hours do you have per aircraft? So I knew that was perfect data. That was some clean data. So I could break that down by medevac data. 2 locations, how much time? Awesome. Then I could say, how long were you in surgery? Okay, I could do approximate amounts because surgical data came from a different database. Not as clean, but okay. What else could I use for severity of wound? Because I was focusing on combat trauma, right? Okay. Blood. Blood usage has to be tracked. For a number of reasons, you have to use blood. So brought in, okay, now I've got a proxy for acuity, severity, and I've got another EHR. I can kind of tie this on. So there I was, Chris, put together a very simple algorithm that we could then post up and say, here is a proxy for relative workload. Interesting. It worked for us, and it worked really, really well, and we ended up publishing some results of that. And so there's my there I was story, but let me continue. Chris, you good? All right. You're welcome, my friend. All right. So today I'm going to talk to you a little bit about who we are, what we support, and I'm going to talk to you a little bit about our new Director of Defense Health Agency, Vice Admiral Bono, and how she's kind of charged us to really focus in as a combat support agency. We're going to talk about kind of meeting the needs through technology. And here's what I promise you is that we're going to talk a little bit about some of our definitions. Definitions specifically of Internet of Things. What does that mean to us? What is our definition of it? And then kind of that whole Martin Luther thing. What does this mean? Right? And how we see this breaking down for us. And so that when you come in and we can talk about Internet of Things, we can talk about mobility, we can talk about other technologies, this is what this means for us. How can we kind of tie this together? I'm also going to spend a little bit of time on analytics of how we're doing our research, and for those that are in this community and we kind of look at our kind of dwindling resources that we have for research, how does this work for us, and how we're kind of looking at things. So, who we are. For those that aren't familiar, this is just a quick thing of the Defense Health Agency, the obligatory slide. So, good? Again, my focus, the military health system, right? All the services. By the way, I mentioned here just briefly the idea of integrating clinical and business process. I'm going to spend a little bit more time. When I talk about utility, I'm going to break down clinical, business, and strategic value a little bit more, because I think that's really important for us to understand. So, Vice Admiral Bono, she says we're supposed to fortify our relationship with services. Again, as Dave mentioned, I came across from Army G3, Army operations before this assignment, right? And before that, Afghanistan, and then have had an opportunity to excel in remote locations a number of times throughout my career. Just excited to do that stuff. So I really love that we're fortifying a relationship with the services. She tells us to strengthen our role as a combat support agency as part of the Fourth Estate. And then to optimize our operations. So what does that mean from a research perspective? I'm going to talk to you about who do I support, what do we offer, and then how we deliver it. This is the mission of the Defense Health Agency, HIT Directorate. So in my job right now, I work for two individuals. I work for the Chief Technology Officer and the Chief Information Officer. Those are the two people I work for. Okay. So what are we focusing on here? For me, it's about culture change, right? You mentioned I had an opportunity to go back a few years ago and work on a doctoral degree, and as I was getting ready to pick different schools, was looking at a number of different schools and different opportunities, and I realized, having deployed a number of times and being on the field, what is my main constraint as a government person working in what I'm working in? Is it always the technology? No, technology is important, but that didn't seem to be what was causing a lot of the problems. Was it straight business case analysis, right? We always do business case. Is it that? No. What it was is colors of money, and more importantly, informal and formal relationships, right? The institutions that exist. And I needed to learn how to, from an economics perspective and political science perspective, how to learn how to kind of deal with those things. And part of that is dealing with cultural change. So this is, for me, like Cotter, developing a sense of urgency. All right? How can I deliver these things? And this, of course, is what we're going to work on. So, folks, let's look at who we support. This is just kind of, a nice slide about the military health system, what we look like, snapshot in time, where we are right now. Again, this is, to me, the soldier that's sitting on the remote mountaintop somewhere, all the way back through that whole chain, right? And this is what this looks like at any one moment. So what do we offer? Data drives decisions. So the group that I work with is called Innovation and Advanced Technology Development Division, and I work specifically in the execution of that. That means executing research as well as how do we then transition. Another reason I think that Dave, actually, as he was leaving military service, wanted to bring me over is that I also have a strong background in acquisition. And so it's important enough for us to be able to tie in what we're doing to the acquisition process. So I get to work on transitioning things to program offices. We're going to spend a little bit of time talking about how we innovate, how we're doing innovation sensing, some strategic planning, as I kind of would pull this back for you, and how we look at some project set valuation. I'll go kind of in depth on those if that's okay. We'll spend a little bit of time. So first is innovation sensing. Okay. So let me just pull this all the way up. Okay. So what we're doing is we take, through innovation sensing, we use a number of different tools. One, we look at corporate product catalogs that already exist, right? I'm a big believer in using disparate data sets, right? Seemingly disparate data sets, and how can we use them? We take the ACM computer classification system, right? That's already out there, that's been developed and is a standard, IEEE Explore. And we take all of these and put them into one, for us, one semantic open source software system, and we kind of put all this information together and kind of mash up the data. So we take all this and we look at corporate product dialogues as well. This allows us to kind of look at what is going on in the technology, landscape. So from there, I can then take that to something a little bit more specific, and then more specifically, I can dig into specific universities. One of the things that I've been working on quite a bit is educational partnerships. I'm going to talk a little bit about that a little later. What does this mean to any folks here from academic community or folks that work with folks in the academic community? A lot of you do. The big take-home point that I talk a lot about is when you go through and you're in academia, you talk about publishing or perish, right? You have to publish in peer-reviewed journals that oftentimes people don't look at, right? And so you work towards tenure over years, and I publish in these journals, and what does this really mean for me? Well, it means a lot to us now. Why? Because we use as part of our innovation sensing, which I know IBM is also working on a lot, is to go out and web crawl for all relevant information in research that we may be interested in. So then I can target from the large technology landscape down to a specific subspace, and then who's doing the research in that area? How many publications are in that area? How many research dollars by using GovWin contracts, things like that, bringing those together. Who's actually getting government contracts right now in this area and in this space? And again, who's publishing? How much are they publishing? So we can then focus our time and energy on certain institutions to help us solve certain problems. So that's how we innovate, and we use innovation sensing. Then we have a tool that's called the Long-Range Strategic Plan. We look at strategic objectives. Again, we'll talk a little bit more about that. And we look at, what are the 2030 plans of the services. So, each one of the services publishes, this is what we think the world and the landscape is going to look like in the next 15 years. Great. So we can take their strategic plan, plug that in. We look at, of course, our quadruple aim and what are the functional gaps that exist. We look at what capabilities and what are our capability gaps that exist in our HR ConOps, as well as looking at other areas such as Gartner modeling and things like that, and we pull this information together. Finally, we can decompose these into a technical solution. Let me show you what this looks like to just focus on different efforts. So for me, I focus a lot of this on implementation, time. There's also some risk factors involved, but also policy. Perhaps there is a very specific technology that we can use, but for a policy reason, one or another, we may not be able to use it right now. We do this in a technical analysis, and then we tie in decomposition of our strategic goals. So, and I apologize, some of these are not building normally the way they would, so it's okay. I'm going to kind of just build these out a little bit more, and then we can chat through them. The first thing, if I can kind of orient everybody to the upper left side, we look at utility. What does utility mean? Again, clinical business value. How much is it going to cost or save, right? Cost savings or cost avoidance. How much is it going to save us, or are we going to be able to avoid cost by creating a new technology or using something that already exists? The other thing that we use is, again, the strategic value to the organization. Sometimes clinical business value isn't going to drive our decision. The example I used at the very beginning of the soldier on the remote mountaintop, that's very expensive to be able to, if you were to look at things from a clinical business value, that is a very expensive thing to do. It is our core business. It is what we are here to do. So we have to add strategic value to our full kind of model of utility. We look at risk. When I talk about risk, of course, most of you have seen, for example, the hype cycle. We could look at hype cycle, but how else do I define risk? We define risk as how many technologies will it take for something to be successful? How mature are each one of those technologies? How ready are we to accept those technologies in our existing architecture? All of this kind of goes into our calculation of what risk looks like. Then we look at these capabilities by project. How many different areas am I helping by doing this? Is this something that's only going to help the operational medicine space? Is this something that is only going to help surgery? Is this something that's going to help a number of different areas, and how can I tie those together? We look at duplicity of efforts. So this is another big thing that we've been working on the last year or so is how many other research efforts within DoD are trying to answer similar or the same problems. So we look at that. We look at across NIH, NSF, other folks that we work with to make sure that we don't have duplicative research. And then lastly, we put all this together and we look at our total utility. So how do we deliver all this? This is a really nice way, and it looks very nice to be able to say, hey, here's our end-to-end model, and everything works like this very logically. But sometimes it does, sometimes it doesn't, right? Some people are smiling like, oh, yeah, we understand. It doesn't necessarily work this way. We use data-driven analysis, right? We're focusing on other divisions within health information technology. We're looking at, again, the ability and the readiness to accept new technologies. We receive ideas, and I'll talk to you at the very end of if you have innovative ideas that you're like, this is something that could perhaps help us. I have a portal that will, this is where you start the process. And I'll be able to also take ideas, things like that afterwards. We can have that conversation. Be glad to take those back to the folks that will ingest those into the system, and we owe you an answer back. By the way, as part of this process, I want to know, and I'm asking you to kind of help me try to break that system. All right? It's a fairly new system that we have for ingesting new ideas, to be able to see if it fits in the portfolio, when it fits in the portfolio. I want to try to break our system. So if we have ideas, great. I'm going to show you exactly where to submit them, and I'm going to see them come through. All right? So please help me with that. We take those. We analyze them. We scope pilots. That is, in the world, those that are used to RDT&E, right? Just so you know, from a health IT perspective, and I'm going to get kind of specific for a second for those that need this kind of information. I want to make sure that you understand. For health IT and informatics, I focus on what's called 6.4 RDT&E. What does that mean in layman's terms? I'm not worried about basic science and research. It is a very important thing, and it has its important place. Places like DARPA, small business innovation research grants, things like that, those are perfect places to be able to do that kind of basic science research. Where we take it is when you have an advanced concept, we have something that is ready to prototype, all right? And when I say prototype, don't think about widgets, but software solutions, things like that we can actually move forward fairly quickly. Our research model currently, and one thing I've kind of focused on a lot over the last 18 months, is to focus research no longer than 2 years in this area. And oh, by the way, as we bring things through, we are bringing things through with a functional user, which is horribly important right from the beginning, as well as those individuals that would end up catching that program down the road. Those that are familiar in the room with our POM, right, so the 5-year POM, we do this and we use a 2-year POP cycle, because by the time that research starts, if I have my functionals there and I have my program executive that'll catch it down the road, if I have them in the room right at the beginning, they can start that process immediately. We understand that some research fails. This research should not fail as often as some of the 6.1 to 6.3, that early research model. Right. So, and those that kind of are familiar with TRL's technology readiness level, that equates to, I'm kind of saying this in like 3 different ways, so you have to forgive me. If you work in TRL world, it is technology readiness level 4, 5, and 6. So if you're familiar with that, and that's where we focus all of our research. So if you look at scoping pilots, you look at bringing something in, that's where we're looking in that area. All right. Hopefully that'll help out. My team helps initiate contracts, execute pilots, and then we help with this whole transition process. We have initiated as well quarterly updates for all of our contracts. So if we have something new that comes in and we want to do a new R&D product, I talked about the entire research project being up to 2 years long. We specifically shorten those POPs, those periods of performance, as short as we can so that we can bring people back in. Is this making sense right now? Is this making sense right now? Are we moving forward? And in any of those meetings, it gets very interesting. It's a great experience for us because I can bring in the functional. I can look at the functional. Does this make sense to you? Okay, great. Does this make sense to you? You're the person that's going to catch us as part of your program. Are we good? And do we have all the other stuff going? Again, this process of acquisition, do we have all the paperwork ready and are we moving forward with it? Right. As well as then the research team to say, okay, now, do you have everything you need to be able to conduct your research? So we do that and we have a good transition program. This is something that had been somewhat, and I'll say it honestly, it had been somewhat problematic in the past. This is one thing that we've really tightened up as the Defense Health Agency has gotten on board and as they have moved to what's called full operating capability at this point. So pretty excited about that. So what are we doing? We're trying to re-engineer. We're making sure everything is a data-driven approach. Those were involved in the past in research. Two things we always heard. One is that it's somebody's science project. We're done with people's science projects, right? This is data-driven. We're focusing on solving specific solutions. And we are trying to diffuse in any way possible to be able to diffuse any of these bottlenecks that exist in our research community. So that's where we focus. One other thing to consider, and it's in that middle slide near the bottom, when we talk about our research within the military health system, there is absolutely a specific space for individual service research. Army does phenomenal research. Navy does phenomenal research. Air Force does AFRL, ONR, ARL. Yep, phenomenal. For us, in our research, we look at joint first. Everything we're doing is joint first. All right. Example of why that's so important to me. Again, in Afghanistan, those that have been around, those that have perhaps even deployed, you understand that in the past, services kind of fought in their own way. Afghanistan in 2012. Of my large facilities that we had that we had command and control over, none of them were Army. The two facilities that we had, one was run by the Navy in the south in Kandahar, and Bagram, which had the long-haul mission to evacuate back to Germany. They were Air Force. Now, a lot of the other work was done by the Army. A lot of these were staffed by different people. Oh, by the way, the fun other thing is we worked quite a bit with our coalition partners, our other hospitals, into the north it was the Germans, the far west it was the Spanish, and then the southwest it was the Brits. And so we all had to work together. So we focus on everything. It's got to be joint first. Another thing that we've worked on recently, and I kind of want to be able to show this, and this is where I'm interested and will be around afterwards to talk with those who wish to talk a little bit more, is our focus on health IT and informatics. By the way, it used to be called just health IT. We've added informatics because, again, what we're doing now is focusing on the data. Data moves, data interoperability, data into black box, data out of black box. When we talk about how we've kind of laid out a roadmap, I showed you earlier this idea of a long-range technical architecture that lays out all the possible technologies, where they are, when they're mature, when we're going to be able to accept them on our architecture. What we've done from a research perspective is then taken this out to the different communities, to the medical logistics community, to the command and control community, operations community, to our joint staff, to our combatant commands, to everyone that we can talk to say, this is what we believe our priorities are, based on documentation, data, things like that. We take that, we've laid out a very specific roadmap, and we have had the opportunity to get very good at establishing what is important to us due to some dwindling resources. So we've had an opportunity to refocus exactly what we're going to focus on. Let me give you just a nice piece on that as well. If you were to focus on research from the military health system over the next 2 to 3 years and look at our roadmap, I'm going to tell you exactly what it means. Focus on operational medicine. Perhaps some of you in the room have seen or been a part of development for the broad agency announcement for 17, and perhaps even some of you have put in research before through our broad agency announcements in health information technology. They used to be very, very broad. We are focused now. We're focused, and for the next couple of years, it is on theater and operational medicine space. That's where we want to focus, all right? So no, that's something to kind of consider if you're looking at, here's a good idea for the future. We need something that is military, medically relevant. Other great ideas, there are tons of them out there. We're excited about those. But they're not going to come through our traditional research door, all right? I just want to be very upfront and make sure folks know about that. So we look at that, and it's got to be something that is, again, very, very focused. Hopefully those that have seen it, there may be like 2 people in the room that hopefully one person afterwards is like, yeah, your broad agency announcement rocks. Okay, probably nobody will do that, but we focused in on that. And then we focus on making sure that this fits into our enterprise strategy. So how are we getting some of the early research done? How are we trying to find out what's going on? For me personally, it has been a focus for the last year is to focus on educational partnerships. What's going on out in academia? We currently have, I don't even think it's up on the screen, we have 16 different partnerships ongoing right now. And this started with some brilliant young minds that we've worked with over the last couple of years that were military, went back to Stanford and Maryland and some other places. And we're doing some cool research, and they needed access to data. So we started with some simple, data use agreements, that sort of thing. And I realized, wait a second, probably other people need this assistance as well. So we focused in historically black colleges and universities. Here's what we have for you. And we've developed, over the last 8 months or so, an a la carte menu of items that we want to be able to help universities with. We're very specific on research dollars that are available. We're very open when it comes to possibilities for data use agreements. If we're looking for possibility of people sharing on committees, coming out and saying, here's a focus for DoD, to be able to have those kind of discussion. Conducting joint research. Our lab in Fort Detrick, Tatrick, right, Telemedicine Advanced Technology Research Center, do a lot of these partnerships. We're doing them out in the PGITIC out in Hawaii as well. And so if there's somewhere we say we can have, or we want to be able to inject some of our research into a data set in a safe environment, .com, .mil, high side, low side, there's all kinds of different opportunities depending on what the university needs. And if it matches our needs, we're glad to work through that with you. And then, of course, just simple counseling of, hey, here's what it looks like to do broad agency announcements. Here's what we have, and here's what's going on right now for us and for you, and to kind of share and go through that. So that's one thing that I just kind of wanted to highlight fairly briefly. So we then focus on, again, I've spent some time talking about this already, the idea of how do we transition things through? Right? Our transition process, again, our transition begins at the beginning now. Right? People have to be on board from the very beginning. We do short periods of performance. We focus on getting things through, out, and move. By the way, when we talked about software, we talked about not doing widgets. By the way, there are other places within military medicine to develop widgets, develop devices, things like that. It's just not through the health IT and informatics community. If someone is interested in, I have widgets, or I have something new, a device or something like that, I would be happy to introduce you to the committees and the other groups that do that kind of work. All right? So just so you know, I'm not saying that this doesn't happen within the military health system. It's just not the focus of our group. All right? And then, of course, we are following in everything that we're doing Kindle's Better Buying Power 3.0, fascinating way. It is a paradigm shift for us in how we do acquisition, and it's very interesting. And we focus on failing early and then moving. All right? So meeting the needs through technology. Internet of Things, I promised I would give kind of a couple definitions. Here's what we're looking for, and here's our definition. So, this is kind of a worrying thing, and again, going back to the old Martin Luther, but what does this mean? how can we shift our focus from healthcare to health? This is another passion of mine. Coming when I was, like I said, when I was working in Army operations, one of our big focuses was on the shift. Our Surgeon General at the time was focused on healthcare to health, General Horoho. And she tagged me to be able to work on contracts supporting this move from healthcare to health and to look at different technologies that were available. In the end, it really wasn't about the technologies, right? It was about the data. And it was about changing knowledge, attitudes, and beliefs, right? Again, efficacy of a device, that was not the concern. Knowledge, attitude, and belief. But how can I shift from healthcare to health? What can I do in that space? How can I be globally ready? And it goes back to, again, my spiel, and this is why I'm very excited. While I'm in uniform, while I get to focus on this is my focus. This is my passion. We have to be able to be relevant and able to project power to wherever we need to support global operations. We talk health. Let me go back real quick before I go to the third. We talked about healthcare to health. What does that mean to a warrior? That's readiness, right? So sometimes you talk about dollars, and dollars are important. It's important to understand, clinical business value, but what is really health? It is about the ability to have folks that can deploy and that can sustain deployments over long periods. And then how do we enable communication between healthcare equipment and systems? So there's a number of things that, in fact, specifically, if you were to take some time and look, the broad agency announcement for FY17 closes next week. If you're interested in finding out more, I'd be happy to talk to you more about that BAA. I'll take your information. I'll have someone send you some information on that. But one of our big area of focus is interoperability, obviously. All right, interoperability of systems. Specifically, we know using some of our modeling that it's very specific to a operational medicine. There are some very specific problems we're trying to solve. There are some large problems with interoperability, and we have some very specific ones that we're trying to solve as well, and love to talk with you afterwards about that. So just some ideas, right? These are the widgets. These are some of the different ideas. Idea here can be active, can be passive, right? There's all kinds of opportunities, all kinds of space available for these. Notice in what we're talking about, most of these are fairly mature technologies, right? If we were to come in and talk about this, how am I integrating into existing systems? All right, so again, integration, interoperability. What does it look like within our space? Right? For me, when we show this, sometimes we show this and people think, this is my clinic at Fort Belvoir, Fort Bragg. For me, when I see this, I think this is that remote location that is sitting, in Kunduz, right? This is something that's sitting perhaps, up in northern, wherever. How can I make all of these systems work? And oh, by the way, the other thing we talked about interoperability, consider specifically operational medicine. Consider low comm and no comm environments, low communications, those times where you don't necessarily have access to the internet, or you have very slow access. All right. I would like to say that that problem has absolutely been solved, and there's no more problems with that. We always have tons of bandwidth wherever we go. The fact is, we still need to be able to answer some of these questions, understanding different environments. Another opportunity, and hopefully some folks in this room have been involved in this and been involved with this for the last couple of years. This is the Global Cities Challenge, where you get an opportunity to bring in minds from academia, government, as well as industry partners to work through some wicked problems. This is one we worked on home to hospital to home. I'm sure this hits for a lot of I hate the idea of telemedicine, telehealth. It's healthcare, right? It just happens to be in a remote location, right? So we focused on this a couple of years ago. Last year, I worked with a small group from Harvard and a few other places, working on some issues that said specifically there's a scenario where you couldn't necessarily touch the patient, right? This is during right before the Ebola outbreak. How could we solve some problems if you weren't allowed to touch the patients? Some really interesting interoperability issues came out of it, and some fun work that was being done on that. So it's kind of a summary, and then we'll just open up for questions. I'll kind of, if it's okay with everyone, I'll stop kind of standing down here. I'm going to walk up there, so if there are questions, I can actually write them down so I make sure I answer them correctly. This is an exciting time for us. We want to be able to coordinate with our federal partners, with academia. I know that we don't have all the answers. This, for me, and this has been kind of an opportunity to come out and say, show me what we don't know. It's okay. We have to work together for a lot of these different issues. Show me what we don't know, and perhaps we can partner. Perhaps there's some opportunity space that's out there. And if we don't have that, discussion, we may not know what we don't know. Plus, if you don't ask the questions, I can't tell you what we're working on right now. And I want to be able to open up and share exactly, as long as it's not acquisition sensitive, exactly what we're doing. Because I think that, and we were talking this morning with some wonderful folks, that's one area that we need to be able to communicate better, is here's our specific needs, all right? And perhaps how can we work together in the future? That's my information. Here's the specifically, if you have a problem, if you have a solution that you think may fit one of our problems, please send it here. Again, there's my information. I am thrilled. If you reach out to me, I will put you in contact with those folks. I focus specifically on the research and execution side. So if I pass you off, please don't think that I'm just kind of, just going to be a kind of a fire and forget, way of dealing with you. I just want to make sure that we're passing off to the right people so that we can get working together. All right. So thank you very much for giving me an opportunity to talk. I'll say thank you again in a minute. But I think if there's any questions, if someone with a microphone, we can open it up. And this is, by the way, this is being brave by asking questions right before lunch. So I appreciate that. So let me go over here so I can write stuff down. Thank you.
So I think during your introduction, Fitbit was mentioned as one of the devices, or I guess that you've implemented. Could you talk briefly about like the challenges and/or successes you've had with personal health record or personal health devices and the analytical part of it?
Okay, so first off, anything that we're doing from our research perspective, we did. Thanks, Dave. We specifically used that device, the Fitbit device, for that initial study and for our second study as well. Anything that we're doing is focused on being device agnostic. So just so you know, I just want to be able to say that off the front. So we looked at a bunch of different things, and this worked well for our pilots that we're using. We're in the middle of doing some other research for some other areas where there's some opportunities out there now. What are some of the big concerns and some of the big issues? Well, one is the patient-generated data, right? There's a lot of policy work that has to catch up to the technology, right? Owner of data, where the data resides, and what's the interaction between the clinician and the patient. One thing that I have done in some of the talks is say we need to stop focusing specifically on physician and patient, because a lot of it, especially a lot of the patient-generated data in some of these fitness trackers, it may, and there's a lot of anecdotal evidence, and there's a growing body of literature that shows, the efficacy of device to outcome, right? However, where is it also really, really relevant? Physical therapy, right? A lot of those other ancillary services. And so we ask people, don't just kind of either say yay or nay, but kind of use these things together. I would say that's probably one of the big issues with this is the patient-generated health data. I'll think of something. There's one other thing I wanted to kind of talk about. Does that help a little bit? Okay, super. Yes.
Hi, my name is Jeff Myers. I'm with REI Systems. We develop, for example, data.gov, so we are focused on transparency in a big way, but also analytics. And I wonder if it's possible to flip to the last slide. Because one of the things I see there is kind of primarily it seems like the folks who are using the analytics are folks within the military, kind of at the health provision level. One of the things we're trying to do, for example, we've developed the FDA data dashboard is instead of targeting just the folks inside the government, it actually target members of the public or members of other stakeholders to do their own analytics and to kind of adopt or behave in ways that are advantageous to both themselves and the government. The example with FDA is the drug companies who want their drugs approved or who want to comply with the law get information from FDA analytics and are therefore better able to do so because they're better informed and they can kind of understand, for example, where FDA is interpreting the regulation to be kind of what's on the good side of the line and the bad side. So my question is kind of the things that I see on this slide are primarily Defense Health wants to lead the way. Defense Health is going to offer personalized health care. Defense Health is going to improve patient care. My question is, are you using analytics so that members of the military or their families can improve their own health, allowing them to access the data in a transparent way and to use it to make judgments that will then lead them to improve their health?
Okay, so great question. Thank you very much. I think there's a couple ways that we can kind of talk about the information that's available for people to make a better informed decision. One is some of the dashboards that are available now and please hold, you have the microphone still? Because I want you to have the microphone because I don't answer your question. I want you to say, no. I specifically am looking for this question. All right? So, thanks. One, the use of some of the dashboards to be able to see patient information. You're talking about specifically that is held in the record? Are you talking about kind of this emergence of the sharing of the
So I imagine there might be several aspects. One is, of course, the patient might want information about their own health record, but the other is they might want to be able to compare themselves to a larger context, maybe to set goals. So presumably it would be kind of in comparison to a larger group of folks whose personally identifiable information has been stripped, but nevertheless to say, we can, as with the blue button, make your information available to you, but we can also provide you with this other information that you can use to do basic analytics and improve your health.
So there are pilots specifically, there is a pilot specifically within the Army that's doing something very similar to that. As far as across the entire military health system, quite frankly, what I'd like to do is be able to get your information and I can tell you a little bit more and have the subject matter expert and data owners be able to answer that question for you. Because I don't want to just kind of speak and say, yes, this is what we're looking at right now, and this is what's kind of being built since I'm kind of living out in the research area. So if you would afterwards, if you can give me your information, I'll be glad to hunt that down and put you in contact with the right people. Fair enough? Okay, no, but I really appreciate that. One thing that we are doing, we're talking about kind of opening up data and specifically opening up, this is tangential only, opening up research. We've actually just recently, within the last few weeks, published all research that has gone on within health IT and informatics over the last 5 years within the military health system space. And that is out on health.mil. And we've published all that information so that in then continuing to work with groups like NSF, NIH, and others to make sure that we have a larger data set that we're feeding our information into. That has been that is a work in progress and something that we're going to continue to work on. So, but I know you weren't focused on research. You're like specifically the patient data. So I'll make sure that I get you in touch with the right people. All right? Thank you. Yes, sir.
You mentioned acquisition, and I'm curious, based on the increasing use or provision by commercial companies of the kind of technology and approaches that you're looking for, are you looking at specific acquisition best practices or reforms within DHA in order to expedite access to those innovative commercial technologies?
Say that last part one more time. I want to make sure because this is another one. So are we focused specifically on our acquisition processes?
That's right. And best practices and other ways to have more streamlined access to innovative commercial technologies.
So I guess the best way to answer that is there has been what? One industry day that was a couple months ago, I believe, a few months ago, right? The practices in a group that has just gone to FOC, I will tell you there is work to do. There's a lot of work that needs to be done within the Defense Health Agency to better streamline that process. I can tell you specifically what we've done on the research side to streamline our process in. But as far as the larger acquisition, I think a lot of people are very interested in, again, that's not my area, but I would be happy to talk with you a little bit more about some of the things that are that I have seen have been somewhat of an issue. I know that we're continuing to get better at that. All right, and I know that has been quite frankly a source of frustration for some. Okay. We're at time. Okay, super. All right. So again, let me just put this right here as my information. I'll be here afterwards. I know everybody else is going to go to lunch. So thank you so much for coming in. More people showed up. That was wonderful. Thank you. And I'll stand by for any other questions, comments, and you have my information. Please feel free to reach out. And again, thank you for giving me the opportunity to come in.